Welcome to the Deep Dive. Today, we're plunging into a topic that is, well, both profoundly challenging and incredibly rewarding for anyone in nursing: the critical moments in postpartum care. While childbirth is often this beautiful, natural process, it can also present sudden, life-threatening complications. Think of this deep dive as your essential guide to being prepared, to understanding what's truly happening beneath the surface when, every second counts.
That's exactly right. For nurses, especially those stepping into maternity care, there's this unique vigilance required. You're kind of balancing routine care with the ever-present possibility of a rapid shift to high-stakes intervention.
Yeah.
It's about developing that instinct, that ability to spot the subtle cues that signal something is dangerously wrong and being ready to act decisively.
Exactly, and this deep dive is really custom-tailored for you, the BSN nursing students listening. We're preparing you for those crucial moments in clinical practice. Our focus is squarely on the most serious postpartum complications, things like hemorrhage, infection, blood clots, and we'll also delve into the specialized field of critical care obstetrics.
Right.
Our mission here is to distill the most important insights, those unmistakable warning signs, and the most effective interventions, empowering you to recognize, respond, and collaborate effectively when these urgent emergencies arise.
And we've meticulously built this deep dive on some really comprehensive information. We'll explore the common physiological complications, from the immediate threat of hemorrhage to the more insidious issues of thromboembolic disorders and infection.
Okay.
Then we'll move into the specialized high-acuity conditions that define critical care obstetrics. Our aim is a clear, structured exploration designed to make complex information digestible and, crucially, memorable, so you feel equipped and ready, not overwhelmed.
Absolutely. This isn't just about theory. It's about equipping you for real-world scenarios where your knowledge can literally make all the difference. Let's get started. First up, let's talk about postpartum hemorrhage, or PPH. This isn't just a concern, it is the leading cause of maternal mortality and morbidity worldwide.
Yeah, it's huge.
The potential for PPH to develop rapidly is significant, and that means quick recognition isn't just important, it's absolutely vital.
It truly is. To provide a clear benchmark, the American College of Obstetricians and Gynecologists, ACOG, defines PPH as a cumulative blood loss of 1,000 milliliters or more.
Okay.
Or any amount of blood loss accompanied by signs of hypovolemia within 24 hours after birth. Now, here's a crucial insight. While we often estimate normal blood loss at, say, 500 milliliters for a vaginal birth and 1,000 milliliters for a C-section.
Right, the standard numbers we learn.
Yeah, research consistently shows these visual estimates are notoriously inaccurate, often underestimated by as much as 50%.
50%, wow.
Yeah, 50%. This underestimation frequently leads to delayed recognition and critically delayed intervention. This is why a simple change in practice, like quantitative blood loss or QBL, has become so impactful.
The QBL.
QBL means we're actually measuring or weighing blood loss instead of just visually guessing. It's a game changer for preventing dangerous delays and, honestly, saving lives.
That distinction between estimated and quantitative blood loss is huge. It really highlights how our practices evolve to become safer. Now, PPH can occur at different times, right? It's not always immediate.
Yes, exactly. PPH is typically categorized by its timing.
Yeah.
We have early or primary PPH, which happens within the first 24 hours after childbirth. This is the most dangerous period, and it's most commonly caused by uterine atony, which we'll definitely dive into.
Okay.
Then there's late or secondary PPH. This occurs after 24 hours and can extend up to 12 weeks postpartum. We'll touch on that later, too.
It's easy to think of the uterus as just a muscle that should contract. But what's truly fascinating, and I think often overlooked, is the incredible physiological tightrope it walks after birth. The real danger isn't just a weak muscle, but how the body's own design for blood flow can suddenly become a liability. Can you peel back that layer for us? Explain why the body sometimes struggles to stop the bleeding.
Absolutely. It's pretty amazing, actually. During pregnancy, the uterus undergoes this tremendous transformation. It enlarges significantly, and maternal blood volume increases by nearly 50%.
Right, prepping for delivery.
Exactly. This is all to support fetal development and, crucially, to prepare the mother for the expected blood loss during delivery. Once the placenta separates from the uterine wall, it leaves behind this large network of open blood vessels.
Okay.
Now, the uterus is exquisitely designed with these thick, interlacing muscle fibers. After the baby and placenta are delivered, these fibers are supposed to contract firmly, acting like a natural tourniquet to compress those open vessels and stop the bleeding.
Like squeezing them shut.
Precisely. However, if that contraction fails, a condition we call uterine atony, Those vessels remain open, and bleeding can just continue unchecked. Other factors can also disrupt this essential process, like trauma to the birth canal, retained placental tissue, or underlying problems with the mother's clotting factors.
So, knowing all that, it becomes incredibly important to identify clients with predisposing factors early on. As a nursing student, this initial chart review and ongoing assessment is really your first line of defense. What kind of situations or conditions are your big red flags for PPH?
Yeah, being proactive here is paramount. Think about anything that either stresses the uterus or impairs the body's ability to clot. So uterine overdistension is a major one. Conditions like multiple gestation, a very large baby macrosomia, or excessive amniotic fluid polyhydramnios, these stretch the uterine muscles to their limit, making them less effective.
Makes sense.
Grand multiparity, having 5 or more boths, can also fatigue the uterus over time. Labor patterns play a role too. Very fast, precipitous, or very long, prolonged labor, especially if it was induced or augmented with oxytocin, can exhaust the uterus.
Okay.
Operative deliveries like forceps, vacuum, or cesarean births, or a difficult third stage of labor, they all increase risk. Abnormal placentation like previa or accreta, these are extremely high-risk situations.
Definitely.
Certain medications like magnesium sulfate or general anesthesia can relax the uterus too much. Underlying coagulation issues, maybe a pre-existing bleeding disorder or DIC, or intrauterine infections like chorioamnionitis also elevate risk. And of course, direct trauma, lacerations, or hematomas from the birth itself.
That's a lot to keep track of.
It is. For you, the critical nursing action is identifying these clients early, make sure they have good ID access, have uterosonic agents ready nearby, and actively manage that third stage of labor according to protocols.
That's an expensive list, but it really paints a picture of how each of those conditions can impact the uterus's ability to do its job. Now, to help manage these situations, there's a clever mnemonic often used. The 4 T's. Let's break those down.
Absolutely. The 4 T's: tone, trauma, tissue, and thrombin provide fantastic framework for quickly identifying and addressing the cause of early PPH. It really helps organize your thinking in a stressful moment.
Okay, let's start with tone. I know that's the most common cause, right?
Right. Tone, specifically uterine atony, accounts for roughly 70% of all PPH cases. It's simply the uterus failing to contract effectively. Those blood vessels at the placental site are left open, leading to potentially rapid blood loss.
So what does that look like clinically? What are you feeling or seeing?
Clinically, you'll feel a fundus that's boggy, soft, maybe displaced to the side.
Right.
You'll see excessive lochia. It might be profuse with large clots, or sometimes it's just a continuous trickle. A key clinical clue is if the fundus firms up temporarily when you massage it, but then quickly relaxes again as soon as you stop. The absolute first and most critical nursing action is immediate, firm fundal massage. And while you're doing that, you have to support the lower uterine segment to prevent uterine inversion. That's crucial.
Right, don't push it out.
Exactly.
Yeah.
If the bladder feels distended, help the client void or catheterize them because a full bladder gets in the way. If atony persists despite massage and emptying the bladder, then you administer ordered uterotonic medications.
That makes perfect sense. Firmness is key. But what happens when the uterus is firm, yet bleeding still continues? That's where trauma comes in, right?
Precisely. Trauma refers to lacerations and hematomas. Lacerations are tears in the birth canal, the cervix, vagina, perineum. Blood vessels are disrupted, causing continuous bleeding even with a well-contracted uterus. That's the key difference.
So the fundus feels fine, but there's still blood.
Yes. You'll see bright red, maybe trickling or steady bleeding despite a firm fundus. That's your big clue for a laceration. Hematomas are localized collections of blood, often in the vulva or vagina. They cause severe perineal or pelvic pain, maybe rectal pressure, and critically, hematomas can be concealed. You might not see external bleeding, but the client will still show signs of hypovolemia, like unexplained tachycardia and hypotension.
Sneaky.
Very. For lacerations, you'll assist the provider with visualization and repair. Small hematomas might get ice packs and pain relief, but larger ones often need surgical incision and drainage. For you, remember this: ongoing bright red bleeding with a firm uterus is not normal. That's a critical sign pointing towards trauma.
Got it. Firm uterus, still bleeding. Think trauma. Okay, and tissue. What should we be looking for there?
Tissue refers to retained placental fragments. If pieces of the placenta or membranes remain inside, the uterus just can't contract completely down. This leads to persistent bleeding and also increases the risk of infection later on.
What are the clues for that?
Clinical clues include persistent bleeding even with a firm uterus, or sometimes the uterus feels firm initially, but then gets boggy again after massage. Often it's linked to an incomplete placenta inspection right after delivery.
Ah, so inspecting the placenta is key.
Absolutely. Nursing actions involve giving uterotonics and preparing the client for potential ultrasound or maybe even manual removal of fragments or a D&C. Here's a critical nursing action. Always, always inspect the placenta carefully after delivery. Missing fragments can cause significant delayed hemorrhage, and this often gets recognized after discharge, which really highlights the importance of thorough client education before they go home. Teach them what to watch for.
That's a great point about post-discharge recognition. Okay, finally, the last T, thrombin.
Thrombin refers to coagulation disorders. This is when the body's ability to clot blood is impaired for some reason. You'll see bleeding persist despite a firm uterus and no obvious trauma.
So everything else seems okay, but the bleeding won't stop.
Exactly. Warning signs include generalized oozing from puncture sites,
Okay.
like IV sites, maybe petechiae, easy bruising, or abnormal lab results like low fibrinogen or prolonged clotting times. If you see these signs, you need to report it immediately and prepare to initiate hemorrhage protocols, which might include replacing clotting factors as ordered by the provider. The critical nursing action here is clear. If bleeding persists without uterine atony or obvious trauma, think coagulopathy and escalate care right away.
Those 4 Ts really provide a structured approach to what can feel like a chaotic situation. Makes it much more manageable. Now, while we mostly focus on early PPH, you mentioned late PPH earlier. Can we quickly cover what that looks like?
Yes, absolutely. Late postpartum hemorrhage, or secondary PPH, happens between 24 hours and up to 12 weeks after birth. The most common causes are subinvolution, which means the uterus isn't returning to its normal size as expected retained placental fragments, or infection. Clients might report prolonged or excessive lochia, irregular bleeding, or sometimes even sudden heavy hemorrhage. They might also complain of pelvic pain, backache, or just persistent fatigue and malaise. Management focuses on stabilizing the bleeding, using uterotonic agents, and potentially ultrasound or D&C to remove any retained fragments. If infection is suspected, antibiotics are key.
And since this often happens after discharge, client education must be a huge part of your role.
Absolutely vital. You need to teach clients how to palpate their own fundus, how to track their lochia progression, rubra to serosa to alba,
Yeah.
and most importantly, recognize warning signs like foul-smelling lochia, new or worsening pelvic pain or fullness, or a sudden increase in bleeding. Empowering families with this knowledge allows them to recognize abnormal recovery and seek care promptly.
So let's synthesize this. What does this all mean for you, the nursing student on the floor? What are your go-to actions when you suspect or encounter PPH?
Okay, your immediate go-to actions include, first, immediate fundal massage to stimulate contractions.
Yep.
Second, check for and empty a distended bladder. Use the bathroom or catheterize. Third, assess the source of bleeding. Run through those 4 T's in your head. Fourth, ensure large bore IV access and administer vital fluids to replace volume and prevent shock.
Big IVs. Got it.
Yes, at least an 18 gauge, preferably 2. Fifth, monitor vital signs and SPIOs frequently, remembering that tachycardia can be an early sign of hypovolemia before blood pressure drops. Don't wait for the BP to fall.
Good point.
Provide oxygen to support tissue oxygenation. Elevate the client's legs to promote venous return. And always, always be prepared for escalation, having uterotonic medications ready, anticipating possible tamponade balloon use, or even surgical interventions.
Often uterine massage and those initial measures aren't enough, and you'll be reaching for specific medications. Can you walk us through the main pharmacological interventions? What are we giving?
Indeed, we have several powerful uterotonic agents in our arsenal. Oxytocin or pitocin is usually your first-line choice. Given IV or IM, it's the standard to get that uterus contracting.
Okay.
Next, methorgonavine, or methergine. This is usually given IM or sometimes orally. Critically, it's contraindicated in clients with hypertension or severe cardiac, renal, or hepatic disease. Always check their blood pressure before giving it.
Crucial check. Methergine and high BP don't mix.
Absolutely not. Then there's carboprost-tromethamine, or Hemabate, given IM. This one is contraindicated in asthma due to the risk of bronchospasm, so you absolutely have to ask about respiratory history. Common side effects are GI upset, diarrhea, nausea, vomiting, so you might give antiemetics or antidiarrheals proactively.
Good tip.
Misoprostol, or Cytotec, is often given rectally for PPH, though it can be given other routes too. It works well, but watch for side effects like shivering and fever. Finally, tranexamic acid, or TXA, given IV. This isn't a uterotonic, it's an antifibrinolytic, It helps stabilize clots that are forming and is often given alongside the uterotonics, usually within 3 hours of birth.
Okay, so it helps stop the breakdown of clots.
Exactly. When giving any of these, your priorities are verify contraindications like BP for methergine and asthma history for Hemabate, document timing, dosage, and the client's response meticulously. Use sequential administration, usually starting with oxytocin, and always be mentally and physically prepared for a massive transfusion protocol if things escalate.
When blood products are needed, it's not just a routine order, is it? It feels like it's often a race against time.
It really can be. Blood transfusion is a life-saving intervention in PPH to prevent shock and organ failure. It replaces lost volume and restores that vital oxygen-carrying capacity. Nurses are absolutely critical for safe practice here, meticulously verifying orders, client identity, checking blood compatibility, using large-bore IVs, and continuously monitoring for adverse reactions, especially in those first 15 minutes.
Right, the transfusion reaction watch.
It's exactly. If you suspect a reaction fever, chills, hives, difficulty breathing, back pain, stop the transfusion immediately, notify the provider, maintain the IV line with saline, and initiate supportive care based on the reaction. When blood loss is truly catastrophic, we activate a massive transfusion protocol, or MTP.
MTP.
Yeah. This is an emergency response for rapid, large-volume blood replacement. It delivers balanced units of packed red blood cells, PRBCs, fresh frozen plasma, FFP, platelets, and sometimes cryoprecipitate, often in a 1.1.1 ratio of PRBCs to plasma to platelets.
Why that specific ratio?
It aims to mimic whole blood and replace not just volume and oxygen carriers, but also the clotting factors and platelets being lost, to help combat coagulopathy that often develops with massive hemorrhage. In obstetrics, NTP gets activated for things like uncontrolled PPH, severe placental abruption, uterine rupture, or DIC leading to massive blood loss.
This raises an important ethical and clinical question. What about situations where medical treatment, like blood transfusion, conflicts with deeply held beliefs? For example, clients who are Jehovah's Witnesses and decline blood products.
That presents unique and incredibly challenging situations in PPH, where rapid blood replacement can genuinely be life-saving. It requires careful planning and communication. For you as a nurse, key considerations begin with early assessment and clear documentation of the client's wishes. These preferences must be communicated effectively to the entire care team, OB, anesthesia, nursing, everyone.
So proactive communication is key.
Absolutely. When blood products are declined, alternative strategies must be maximized. This means using all available uterotonic medications, administering tranexamic acid early to promote clot stability, and optimizing intravascular volume, using IV crystalloids and colloids aggressively. Interventional radiology options like uterine artery embolization or surgical options like compression sutures or even hysterectomy might be considered sooner than in other cases.
Right, you have fewer rescue options.
Exactly. Collaboration is vital, often involving the ethics committee or chaplaincy alongside the medical teams. Nurses play a crucial role in advocating for patient autonomy while ensuring every possible alternative treatment is utilized to protect maternal health and safety. It requires sensitivity and respect for their beliefs while managing a critical situation.
After such a traumatic event like a hemorrhage, care doesn't just stop once the bleeding is controlled, does it? What does post-hemorrhage care and home care look like?
No, definitely not. Post-hemorrhage care involves frequent assessments for any recurrence of bleeding. These clients will almost certainly be anemic and extremely fatigued. So nursing care involves clustering activities to allow for rest. Monitoring carefully for orthostatic hypotension when they first get up, they can get dizzy easily.
Good point.
Encourage iron-rich foods and fluids, administer iron supplements as ordered, and offer extra support with newborn care because they'll likely lack energy. For home care, it's crucial to educate clients and their families that prolonged fatigue is common. Anemia often necessitates ongoing iron therapy for weeks or months. Activity may need to be restricted initially. It's also important to acknowledge that this fatigue can sometimes interfere with bonding, so families might require extra support systems or resources.
An infection risk.
Yes, absolutely. Teach them the signs of infection to report promptly, things like fever, foul-smelling lochia, or worsening pelvic pain. Clear discharge instructions are vital.
Now let's connect this directly back to PPH. We talked about blood loss, but there's a critical threshold. Think of it like a cascade. Once that physiological reserve is gone, the body struggles, and it struggles fast. Let's talk about hypovolemic shock.
You're absolutely right. During and after birth, a client can usually tolerate a blood loss that approaches the additional blood volume gained in pregnancy, which is roughly 1,500 to 2,000 milliliters.
Okay, quite a bit.
It is, but this reserve is finite. And clients who start off with pre-existing anemia or perhaps severe preeclampsia, they have less capacity to compensate even before they reach that amount of loss. Hypovolemic shock is essentially an acute peripheral circulatory failure due to the loss of circulating blood volume. This deprives vital organs, brain, heart, kidneys of oxygen. It creates this downward spiral of hypoxia, metabolic acidosis, and organ failure that can rapidly progress to maternal death if it's not recognized and treated aggressively.
Here's where it gets really interesting and often missed. The body's own compensatory defenses can actually hide the danger initially.
Precisely. This is so important to understand. Recognition of hypovolemic shock can be dangerously delayed because the body compensates quite effectively at first. It does this by increasing the heart rate, increasing the respiratory rate, and constricting peripheral blood vessels to shunt blood towards the core vital organs. These mechanisms maintain blood pressure initially.
So the BP looks okay for a while.
Exactly. They effectively mask the true severity of the blood loss until the body just can't compensate anymore. By the time the client's blood pressure actually falls, significant, often critical, blood loss has already occurred.
Wow.
This is why a critical nursing insight, something you absolutely need to burn into your brain, is to not wait for hypotension before escalating care. Tachycardia, a persistently elevated heart rate, a subtle increase in respiratory rate, cool, pale, or clammy skin, maybe some anxiety or restlessness. These are often the earliest and most crucial warning signs.
So for you as a nursing student facing this, what are your absolute priority assessments and interventions when you suspect hypovolemic shock is developing?
Okay, your priority assessments start with that ongoing evaluation of the fundus. Is it firm or boggy? Check for bladder distension. Critically, quantify blood loss accurately. QBL is essential here, weighing pads and chucks.
Don't just eyeball it.
No, definitely not. And most importantly, continuously monitor vital signs, pulse, respirations, O2 sat, temperature, and BP, but interpret them together. Remember, a normal blood pressure can be deceiving early on. Look for that persistent tachycardia, often 110 BPM, increased respiratory rate, 22-24, and look at the skin. Is it becoming cool, pale, or clammy? Is urine output dropping below 30 mAr? Is the client becoming restless or confused?
Putting all the pieces together.
Yes. If you suspect hemorrhage progressing toward shock, your immediate interventions are: initiate firm fundal massage, address bladder distension, notify the provider immediately using clear communication like SBR. Establish large bore IV access again, 2 lines if possible, and start infusing warmed crystalloid fluids like lactated ringers or normal saline rapidly. Provide oxygen via non-rebreather mask at 10-15 Elminins. Position the client flat initially or with legs elevated slightly, modified Trendelenburg, to help promote venous return, unless contraindicated. Keep them warm. This immediate coordinated response is crucial to control the bleeding source and restore volume to prevent irreversible shock.
Okay, moving on from the storm of excessive bleeding, sometimes the body's own defense mechanisms, the ones meant to prevent hemorrhage, can create a different, equally life-threatening problem: blood clots. Expert, can you explain the twin dangers of thrombus and embolus?
Certainly. It's another critical area of postpartum vigilance. A thrombus is basically a blood clot, a collection of blood components like platelets and fibrin that forms along the wall of a blood vessel. If it causes inflammation in the vessel wall, we call it thrombophlebitis.
Oh, okay.
And embolus is the dangerous part. It's a piece of that thrombus, or sometimes other material like air or amniotic fluid, that breaks free from its original site and travels through the bloodstream. It can then lodge in another part of the body, often obstructing blood flow. When it lodges in the pulmonary artery in the lungs, it causes a pulmonary embolism, or PE, which is a potentially fatal complication.
So a traveling clot.
Exactly. In the perinatal period, the 2 most concerning thromboembolic conditions are deep vein thrombosis, DVT, which is a clot forming in the deep veins, usually of the legs or pelvis, and pulmonary embolism, PE, where that clot travels to the lungs. Together, these are often referred to as venous thromboembolism, or VTE. For you, a critical nursing insight is to maintain a high level of suspicion for VTE. Any postpartum client presenting with unexplained calf pain, swelling, sudden shortness of breath, or sudden tachycardia requires immediate evaluation. Don't dismiss these symptoms.
So why are pregnant and postpartum clients at such significantly high risk for these blood clots? It seems counterintuitive sometimes.
It does, but there's a strong physiological basis. The increased risk for VTE during pregnancy and postpartum is best explained by what we call Virchow's triad. It's a classic concept describing 3 primary factors that create the perfect storm for clot formation.
Virchow's triad, okay.
First, venous stasis, which just means slowed blood flow. The enlarging uterus puts pressure on the large pelvic veins, obstructing flow from the legs. Plus, decreased mobility during late pregnancy or after delivery, especially after a C-section, further slows venous return.
Right, blood pooling.
Exactly. Second, hypercoagulability. Pregnancy is naturally a hypercoagulable state. The body increases the levels of clotting factors and decreases the activity of anticoagulant proteins. It's basically the body's way of preparing to prevent excessive bleeding or hemorrhage at birth. But this protective mechanism also increases the risk for abnormal clotting.
A double-edged sword.
Precisely. And third, vessel injury. Trauma to the blood vessel walls can occur during labor and delivery itself, particularly with operative deliveries like forceps or vacuum, or during a cesarean section. Even FERV insertions can cause minor vessel injury. These injury sites provide surfaces where clots can more easily form.
So stasis, hypercoagulability, and injury.
Yes, and because pregnancy inherently causes both venous stasis and hypercoagulability, all pregnant and postpartum clients are, by definition, considered to be at increased risk for VTE compared to non-pregnant individuals.
Given that inherent risk across the board, what are some of the additional specific risk factors that really elevate the danger, the things that make you extra vigilant?
Beyond the baseline risk from Virchow's triad, several factors significantly increase the VTE risk. A previous history of thrombosis is a major one. If they've had a clot before, their risk is much higher.
Makes sense.
Known thrombophilias, inherited or acquired disorders that make blood clot more easily. Cesarean birth, especially emergency C-sections, significantly increases risk compared to vaginal delivery. Prolonged labor or prolonged immobility or bed rest. Obesity is a significant risk factor. Pre-existing conditions like heart disease, diabetes, hypertension, certain autoimmune disorders, or sickle cell disease.
Okay.
Also, infection, advanced maternal age, usually considered over 35, having multiple babies, multiparity, a family history of clots, or even things like prolonged air travel. For nurses, remember the risk is not uniform throughout the postpartum period. It's actually highest in the first postpartum week. So vigilant assessment during this critical time is absolutely key.
Let's focus on deep vein thrombosis, or DVT, first. What are your key clinical clues for recognizing it? What should you be looking for, and what's the immediate management approach?
Okay, a DVT can sometimes be silent, meaning the client has no obvious symptoms. But often it presents with pain, usually described as aching or cramping, in the leg, groin, lower back, or even the abdomen, depending on which vein is involved.
So pain is common.
Yes. You might also see swelling, edema, in the affected leg, sometimes redness, erythema, warmth, and tenderness when you palpate the area. The skin might even appear pale and cool if there's associated arterial spasm. Clients often report pain specifically on ambulation, or sometimes chills, malaise, or stiffness. It most often affects the left leg due to anatomical compression of the left iliac vein.
Left leg more often. Okay. How is it diagnosed?
Diagnosis is typically confirmed with a venous Doppler ultrasound of the affected extremity. It's non-invasive and pretty reliable. Sometimes an MRI might be needed, especially if a pelvic clot is suspected. D-dimer tests are generally unreliable during pregnancy and postpartum because levels are naturally elevated then.
Good to know about the D-dimer. What about management?
Management really focuses on prevention first, and then immediate treatment if a DVT occurs. Prevention involves identifying high-risk clients and potentially using prophylactic anticoagulants like low molecular weight heparin, LMWH. Encouraging early ambulation postpartum is huge. Using sequential compression devices, SEDs, especially for C-section clients or those with other risk factors, is standard practice. Padding stirrups and limiting time in stirrups during birth also helps.
And if a DVT is diagnosed?
Once a DVT is diagnosed, initial treatment involves therapeutic anticoagulation, usually starting with heparin or LMWH, to prevent the clot from getting bigger or breaking off. Bed rest with the affected leg elevated helps reduce swelling and pain. Analgesics are given for pain relief. Sometimes moist heat is applied. After the initial phase, anticoagulation is typically continued for at least 6 weeks postpartum, often longer depending on the situation, potentially transitioning to warfarin postpartum, which is safe for breastfeeding. Clients are taught lifestyle modifications like avoiding tight clothing, not crossing their legs, avoiding prolonged sitting, staying hydrated, and moving frequently during travel.
Moving to an even more dangerous complication, pulmonary embolism, or PE. What's happening physiologically here, and what are the absolute can't-miss signs and symptoms?
A PE occurs when a thrombus, usually from a DVT in the legs or pelvis, breaks free, travels through the heart, and lodges in the pulmonary arteries, obstructing blood flow to the lungs. The severity depends entirely on the size of the clot and how much of the pulmonary circulation it blocks. Small PEs might give you some time to treat, but large saddle emboli blocking the main pulmonary artery can cause sudden cardiovascular collapse and death.
Terrifying. What are the symptoms?
Clinical manifestations can be very sudden and dramatic, but sometimes subtle initially. Dyspnea, or shortness of breath, is the most common symptom, often with sudden onset. Chest pain, often pleuritic, worsens with breathing, is also very common. Clients frequently report a profound sense of impending doom or severe anxiety, sometimes even before other physical symptoms fully manifest. Don't dismiss that feeling.
Okay, that sense of doom is a real sign.
It absolutely is. You'll also typically see tachycardia, fast heart rate, tachypnea, fast breathing, and hypoxemia, low oxygen saturation. Sometimes they might have a cough, occasionally with hemoptysis, coughing up blood, crackles in the lungs, or a low-grade fever. With massive emboli, you might see sudden hypotension, syncope, fainting, or signs of shock. Oxygen saturation will definitely be decreased.
How is PE diagnosed?
Diagnostics usually start with assessing oxygenation, ABGs, pulse oximetry. A chest x-ray might show subtle signs, but is often normal. The gold standard diagnostic test is usually a CT pulmonary angiography, CTPA, which visualizes the pulmonary arteries. A VQ scan is another option, especially if CT contrast is contraindicated. A Doppler ultrasound of the legs might also be done to look for the source DVT.
What's the nursing response?
For nurses, this is a true medical emergency. You must assess and report early warning signs like sudden air hunger, dyspnea, pallor, cyanosis, or unexplained tachycardia without delay. Your immediate actions are crucial. Stay with the client. Raise the head of the bed to facilitate breathing. Apply oxygen immediately via non-rebreather mask at 810 Elmanin or higher to maintain saturation. Call for immediate assistance, activate the rapid response scheme, or call a code depending on stability. Anticipate orders for IV heparin administration, analgesics like morphine for pain and anxiety, and potentially transfer to critical care. The critical nursing action to remember is that any postpartum client who suddenly develops chest pain, dyspnea, or tachycardia must be treated as having a PE until proven otherwise. Act fast.
So, bringing it back to the nursing process again, when you suspect a thromboembolic event, whether DVT or PE, what's your immediate assessment focus and what are your priority interventions?
Okay, for assessment, beyond reviewing those risk factors in the chart, you're looking for those key clinical manifestations we just discussed. For a suspected DVT, assess the extremities for pain, swelling, warmth, redness, tenderness. Compare calf circumferences, check pedal pulses, ask about pain with ambulation. For a suspected PE, assess respiratory status, immediately rate, effort, oxygen saturation, listen for breath sounds, ask about chest pain, dyspnea, check heart rate and rhythm. Look for signs of anxiety, restlessness, or that sense of impending doom. Monitor vital signs continuously, check their emotional status. They will likely be very anxious or fearful.
And the problems identified.
The key client problems identified would be ineffective peripheral tissue perfusion related to the venous obstruction for DVT, and impaired gas exchange related to altered blood flow to the lungs for PE. Also, acute pain, anxiety, fear, and risk for injury related to anticoagulation therapy.
So planning and interventions follow directly from that.
Exactly. Your planning immediately shifts to expected outcomes like maintaining adequate oxygenation and perfusion, managing pain, reducing anxiety, and preventing further clot propagation or embolization. Priority interventions for DVT include maintaining bed rest initially with the leg elevated, administering anticoagulants as ordered, and monitoring labs like APTT or anti-axle levels depending on the agent, applying warm, moist compresses for comfort, providing analgesics, and eventually progressing to gradual ambulation with compression stockings. For PE, the priority interventions are immediate high-flow oxygen, 8-10 Lmin or more via mask, elevating the head of the bed, staying with the client to provide reassurance, administering narcotic analgesics like morphine for pain and air hunger, anticipating IV heparin bolus and infusion, and calling for immediate assistance ICU transfer. This is all about rapid recognition, immediate life-sustaining intervention, and seamless collaboration with the medical team in respiratory therapy. You also need to provide clear, simple explanations and emotional support to the client and their family during a very frightening time.
Okay, moving from blood loss and clots to another major postpartum threat infection. This was once, almost a death sentence before antibiotics, and it's still a really serious global issue.
Indeed it is. Puerperal infection refers to bacterial infections of the reproductive tract occurring after childbirth. Before the era of antibiotics, puerperal sepsis or childbed fever was a leading cause of maternal death. Even today, it remains a significant cause of maternal morbidity and mortality worldwide, especially in resource-limited settings.
How do we define it clinically?
We generally define it as a temperature of 38 degrees C, that's 100.4 degrees Fahrenheit, or higher after the first 24 hours postpartum, occurring on at least 2 of the first 10 days after birth. It's important to note that a mild temperature elevation within the first 24 hours can sometimes be normal, related to the exertion of labor or dehydration, but a fever persisting or starting after that first day is suspicious for infection.
Okay. What are the common types of infections we see?
The most common types include endometritis, which is an infection of the uterine lining, wound infections affecting C-section incisions, episiotomies or lacerations, urinary tract infections, UTIs, and mastitis, which is an infection of the breast tissue.
So why is the postpartum client uniquely vulnerable to infection? What changes happen that increase this risk?
Several physiological factors contribute to this vulnerability. First, the reproductive tract itself, particularly after delivery, provides an easy pathway for bacteria normally present in the vagina or perineum to ascend upward into the uterus. Second, the pelvic region has a very rich vascular and lymphatic supply, which means if an infection takes hold locally, organisms can potentially spread systemically quite rapidly, leading to septicemia.
Okay, easy spread.
Yes. Third, the normally acidic vaginal environment, which helps keep bacteria in check, is altered by the presence of alkaline lochia after birth, favoring bacterial growth. Fourth, the uterine cavity after birth contains necrotic endometrial tissue and lochia, which serves as an excellent culture medium for bacteria to proliferate. And finally, even a normal birth can cause microscopic breaks or lacerations in the tissues, providing entry points for bacteria.
So a perfect storm scenario.
It can be. For you, the critical nursing insight is to remember that while the body has natural defenses, like white blood cells in the lochia and good hygiene practices, these physiological changes create a perfect environment for bacteria to take hold if vigilance or proper care falters.
On top of those baseline physiological changes, what are some additional specific risk factors that you'd highlight? Things that make infection even more likely?
Absolutely. The single most significant risk factor for postpartum infection, especially endometritis, is cesarean birth, mainly due to the surgical incision and introduction of bacteria into the uterus.
Okay, C-section is number one.
Yes. Other key factors include prolonged rupture of membranes, more time for bacteria to ascend, prolonged labor, more vaginal exams, tissue trauma, multiple vaginal examinations during labor, the use of internal fetal monitoring like scalp electrodes or intrauterine pressure catheters. Also, manual removal of the placenta, significant birth trauma like large unrepaired lacerations or difficult operative deliveries, urinary catheterization, having retained placental fragments, and experiencing a postpartum hemorrhage, which can compromise the immune response.
Underlying conditions matter too.
Definitely. Prenatal conditions like anemia or poor nutrition can weaken defenses. Any pre-existing infections like Group B strep colonization or chlamydia increase risk. And of course, poor hygiene practices or lack of access to clean facilities contribute significantly, especially globally. A critical nursing action related to this is teaching clients that a foul odor in their lochia, developing a fever, or experiencing new or worsening abdominal pelvic pain are significant warning signs that must be reported promptly to their provider.
Let's look at some of these specific postpartum infections in more detail, starting with endometritis, the uterine lining infection. That sounds pretty serious.
It is the most common puerperal infection, especially after C-sections, where incidence can be 5–15% or even higher without prophylactic antibiotics. It's usually polymicrobial, meaning multiple types of bacteria are involved.
How does it present?
Clients with endometritis often appear acutely ill. They typically present with a fever of 38 degrees C or higher, often developing within 36 hours postpartum, sometimes accompanied by chills, general malaise or feeling unwell, lower abdominal pain or cramping, and significant uterine tenderness on palpation. The lochia is often increased in amount, may be dark and purulent, and characteristically has a foul odor. Tachycardia is common, and the uterus may not be shrinking down as expected, subinvolution. Lab work usually shows leukocytosis, high white blood cell count.
How is it managed?
Management centers on prompt administration of 5E broad-spectrum antibiotics. Common regimens include drugs like cephalosporins or a combination like clindamycin plus gentamicin. 4V therapy is usually continued until the client has been afebrile for at least 24 hours. Prophylactic antibiotics given just before C-sections have dramatically reduced the rates of endometritis. Antipyretics for fever and sometimes oxytocics to promote uterine drainage might also be used.
Are there complications if it's not treated properly?
Yes, Untreated or inadequately treated endometritis can spread, leading to more serious complications like infection of the fallopian tubes, salpingitis, or ovaries, ophiritis, generalized pelvic infection, peritonitis, pelvic abscess formation, or a septic pelvic thrombophlebitis, infected clot in pelvic veins. Signs of these would be worsening severe abdominal pain, persistent high fever despite antibiotics, nausea, vomiting, or signs of an ileus like abdominal distension and absent bowel sounds.
So nursing care focuses on
Nursing care focuses on administering antibiotics on time, providing pain relief, closely monitoring vital signs every 2 to 4 hours initially, and assessing for signs of improvement or worsening, like decreasing fever, reduced tenderness, changes in lochia, return of bowel sounds. Providing comfort measures, encouraging fluid intake, teaching the client about signs of worsening infection, and importantly, facilitating maternal infant attachment as much as possible, perhaps encouraging pumping if they are temporarily separated due to illness. Infection really delays recovery and can interfere with bonding, so emotional support is key.
what about wound infections, especially after C-sections or significant perineal trauma?
Wound infections are also quite common, affecting C-section incisions, episiotomies, and repaired lacerations. Risk factors include obesity, diabetes, hemorrhage during surgery, underlying chorioamnitis, or long-term corticosteroid therapy.
What do these look like?
Clinical manifestations are usually localized to the wound site. You'll see edema, swelling, warmth, redness, erythema, tenderness, and pain. There might be separation of the wound edges, dehiscence, and often seropurulent, pus-tinged fluid drainage. The client might also have a fever and malaise. Rarely, a very serious, rapidly spreading infection called necrotizing fasciitis can occur.
How are wound infections treated?
Management typically involves opening and draining the infected area, obtaining a culture of the drainage, starting broad-spectrum antibiotics, providing analgesics for pain, and using local care measures like warm compresses or sitz baths for perineal wounds. Necrotizing fasciitis requires urgent surgical debridement. Nursing considerations focus on comfort measures, sitz baths, perineal care using a peribottle, meticulous hygiene education, emphasizing front-to-back wiping, frequent pad changes, thorough hand washing before and after care, encouraging fluids and good nutrition to promote healing, potentially modifying activity, preventing the infant from direct contact with affected drainage, and providing reassurance, as needing readmission or home health care for wound management can be very discouraging for the new parent.
A critical nursing action here.
Absolutely report any signs of wound dehiscence, purulent drainage, or rapidly spreading redness or necrosis immediately.
Urinary tract infections or UTIs are also common in the general population. Are they more common postpartum?
Yes, they are relatively common postpartum. This is often due to trauma to the bladder and urethra during birth, urinary stasis from decreased bladder tone after delivery, and the frequent use of catheterization during labor or for C-sections. Residual urine left in the bladder provides a great environment for bacteria like E. coli, the most common culprit, to multiply. Risk factors include frequent vaginal exams during labor and having asymptomatic bacteriuria during pregnancy.
What are the symptoms?
Symptoms usually appear on day 1 or 2 postpartum. The classic signs are dysuria, painful urination, urgency, frequency, and sometimes suprapubic pain or hematuria, blood in urine. Usually it's associated with a low-grade fever. If the infection ascends to the kidneys, it causes pyelonephritis, which is more serious and typically presents later, maybe day 3 or 4, with chills, a spiking high fever, costovertebral angle, CVA, tenderness or flank pain, nausea, and vomiting.
How are UTIs treated?
Uncomplicated lower UTIs, cystitis, are usually treated with outpatient oral antibiotics that are safe for lactation. Pyelonephritis typically requires hospitalization for IV antibiotics and hydration. Urinary analgesics like phenazopyridine might be given for symptom relief. Nursing considerations include ensuring the client completes the full course of antibiotics, encouraging fluid intake of 2,500 to 3,000 milliliters daily to flush the urinary tract, teaching about urine acidification, like drinking prune or cranberry juice, though evidence is mixed, and avoiding bladder irritants like grapefruit juice or carbonated drinks. Reinforce prevention strategies. Good perineal hygiene, voiding frequently every 2-3 hours, and maintaining high fluid intake. Untreated pyelonephritis can lead to kidney damage or sepsis.
And finally, mastitis, that painful infection of the breast tissue. What causes that?
Mastitis affects about 5% of breastfeeding clients, usually developing 2 to 4 weeks postpartum, though it can occur anytime during lactation. It's typically caused by bacteria, often Staphylococcus aureus, including MRSA, or Streptococci, entering the breast tissue through cracked or traumatized nipples. Milk stasis and complete emptying of the breast is a major predisposing factor, as stagnant milk provides a medium for bacterial growth.
What are the risk factors?
Key risk factors include skipped feedings or abrupt weaning leading to engorgement, poor latch or ineffective sucking leading to incomplete emptying, nipple trauma or cracks, wearing overly tight bras that constrict milk ducts, and maternal fatigue or stress, which can lower immunity.
How does it present? It sounds miserable.
It usually presents with flu-like symptoms, often appearing before the localized breast signs. So the client might suddenly feel awful with fever, often high like 39 degrees C or 102.2 degrees Fair, chills, malaise, headache, and muscle aches. Then localized breast symptoms appear. Typically a unilateral, tender, hot, swollen, wedge-shaped area of redness in one breast. The associated axillary lymph nodes might be enlarged and tender. If not treated promptly, it can progress to form a breast abscess.
How is mastitis managed?
Management involves prompt treatment with antibiotics, usually for 7–10 days. Crucially, continued emptying of the affected breast is vital, either through continued breastfeeding, starting on the unaffected side first, then switching, or regular pumping every 1.52 hours. Milk stasis must be avoided. If an abscess develops, it usually requires surgical drainage. Comfort measures include applying moist heat before feeding to encourage letdown, using ice packs after feeding for pain and inflammation, wearing a supportive but not tight bra, increasing fluid intake, getting plenty of rest, and taking analgesics like ibuprofen.
So continued breastfeeding is actually recommended.
Yes, absolutely. The infection is in the breast tissue, not usually the milk itself, and continued emptying is key to resolving the infection and preventing abscess formation. Stopping breastfeeding abruptly on the affected side will likely make it worse. This is a critical nursing action. Encourage continued breastfeeding or pumping even with mastitis or an abscess. Never allow milk stasis to persist. Provide lots of emotional support and education, as mastitis can be very painful and discouraging, often leading mothers to consider weaning prematurely. Prevention is also key, teaching correct latch, positioning, frequent feeds, avoiding nipple trauma, and managing engorgement effectively.
Okay, let's bring this all together with the nursing process for infection overall. What are you assessing for consistently, and what are your absolute priority interventions for prevention and management?
For assessment, it's about constant vigilance. Review those risk factors on admission and throughout their stay. Monitor for both systemic signs of infection fever, tachycardia, chills, malaise, and localized signs depending on the potential site, uterine tenderness, foul or abnormal lochia, wound inspection, redness, edema, warmth, drainage approximation, urinary symptoms, dysuria frequency, or breast changes, redness, heat, pain, cracks. For nurses, a key takeaway is do not overlook small symptoms like unusual fatigue, muscle aches, or just not feeling right. These, especially when combined with other subtle signs or risk factors, may be early indicators of developing infection.
And the main problem?
The overarching client problem is always the potential for infection, which becomes an actual problem. Risk for infection becomes infection when signs and symptoms appear or risk factors are high.
So interventions focus heavily on prevention.
Yes, prevention is paramount. Priority interventions focus on promoting meticulous hygiene, strict hand washing by staff and the client, use teachback, proper perineal care with peribottle use after each void BM, frequent pad changes every few hours, and always wiping front to back. To prevent urinary stasis, encourage good oral fluid intake and frequent voiding every 2–3 hours. Use non-invasive strategies first if they have difficulty voiding, and provide analgesics if pain is inhibiting urination. For breastfeeding clients, teach and reinforce effective techniques, ensuring a correct latch and positioning, encouraging feeding on demand, ensuring breasts are emptied regularly and completely. Provide essential information and support. Educate about the importance of rest and good nutrition for healing and immunity. Encourage them to utilize family support systems and provide clear, understandable discharge teaching on the warning signs of infection they need to report. Clear teaching and reassurance decrease anxiety and empower clients to participate in their own care and recovery.
A critical point here.
Critically, delayed recognition of infection can quickly lead to systemic illness, sepsis, and even death. Be vigilant for even subtle signs and escalate concerns promptly.
This is probably one of the most important practical takeaways for you as a nursing student, really learning how to tell the difference between normal postpartum recovery changes and a red flag indicating infection. Let's try to compare those side by side.
Absolutely. This distinction is crucial for timely intervention. Let's simplify it across key areas. Temperature. A slight elevation, up to 38 degrees C, 100.4 degrees Aris in the first 24 hours can be normal due to exertion dehydration. Warning sign. A temperature of 38 degrees C or higher after the first 24 hours, or any persistent fever, or a fever recurring after being normal. Lochia, vaginal discharge. Normally, it progresses predictably from rubra red to serosa pink-brown to alba, white-yellow, with a mild, fleshy, earthy odor. Warning sign. Foul-smelling lochia, a sudden return to heavy, bright red bleeding after it had lightened, could indicate late PPH or retained tissue infection, or lochia rubra lasting longer than expected. Uterus. Should feel firm, be midline, and gradually descend into the pelvis about 1 centimeter, 1 finger breadth per day. Should be non-tender or only mildly tender initially. Warning sign. Subinvolution. Uterus feels boggy, soft, and remains high in the abdomen, or significant uterine tenderness, especially if accompanied by fever or foul lochia, suggest endometritis. Incision episiotomal laceration. Mild redness, edema, and tenderness around the site are normal for the first 24-48 hours as healing begins. Warning sign. Increasing redness, warmth, edema, or pain. Any purulent pus-like drainage, separation of the wound edges, dehiscence. Urination. Some mild stinging or dysuria might be present initially due to perineal trauma, but should improve quickly. Warning sign. Persistent dysuria, urgency, frequency, hematuria, blood in urine, or suprapubic pain suggests UTI. Breasts. Some fullness, firmness, and mild discomfort associated with engorgement when milk comes in around day 3 to 5 is common. Warning sign. Localized wedge-shaped area of redness, heat, significant pain, and swelling in one breast, often accompanied by fever, chills, and flu-like symptoms, suggests mastitis. Bilateral engorgement is usually normal. Unilateral signs with fever are concerning. General condition. Fatigue is very common and expected. Appetite should gradually improve. Warning sign. Experiencing chills, profound malaise, or body aches beyond normal postpartum fatigue, persistent tachycardia, or worsening pain anywhere.
That comparison is really helpful.
Encouraging clients to keep a simple symptom diary can sometimes help them recognize subtle changes early. The critical nursing action, again, is to teach clients, and reinforce for yourself, to report any fever lasting more than 24 hours, any foul-smelling drainage, severe or worsening pain, or signs of systemic illness immediately, both in the hospital and after discharge.
Okay, we've covered those, let's call them common, but still very serious complications. But sometimes things escalate far beyond routine postpartum care. This is where critical care obstetrics comes in, which is a fascinating and, unfortunately, increasingly vital subspecialty.
You're absolutely right. Critical care obstetrics, or CCO, truly bridges the worlds of obstetric nursing and intensive care nursing. It requires advanced knowledge and really high-level clinical skills to manage critically ill pregnant or postpartum clients. This field has grown significantly, sadly, due to the rising rates of severe maternal morbidity and mortality we're seeing in the U.S. and globally.
So hospitals are adapting.
Yes. Hospitals are now often categorized by levels of obstetric care, level 1, 2, 3, 4, similar to trauma centers, to ensure clients receive care in facilities equipped to handle their level of risk. However, a fundamental principle is that every facility providing maternity care must be prepared for the initial stabilization of obstetric emergencies and have clear protocols for safe and timely transfer to higher levels of care when needed.
And this isn't just standard nursing or even standard ICU training, is it? You need specialized training for this.
Precisely. Standard nursing or even general critical care training often isn't sufficient. It doesn't fully equip nurses to manage the unique physiological and hemodynamic changes of pregnancy and postpartum in a critically ill client. Nor does it typically incorporate considerations for fetal well-being alongside maternal resuscitation.
Right, 2 patients.
Exactly. Specialized CCO training usually includes advanced didactic coursework focusing on obstetric critical care conditions, high-fidelity simulation drills, and ongoing competency validation. A critical nursing insight here is that in obstetric emergencies, being proactive rather than reactive is absolutely vital. Hospitals effectively use strategies like obstetric rapid response teams, standardized emergency protocols with clear clinical triggers, and regular simulation training for those high-risk, low-frequency events like massive hemorrhage, eclampsia, or maternal cardiac arrest. Practice makes perfect, or at least makes response more effective.
This brings us to the, frankly, stark reality of maternal mortality and severe maternal morbidity, or SM.
Yes, it's a reality we have to confront. Despite medical advances, maternal mortality remains a pressing public health concern in the U.S. An estimated 700 pregnancy-related deaths occur each year. And importantly, data consistently reveal that about 3 out of 5 of these deaths are preventable.
3 out of 5 are preventable. That's staggering.
It is. Maternal Mortality Review Committees, MMRCs, in many states meticulously evaluate these deaths to identify contributing factors and recommend prevention strategies. Beyond actual deaths, there's severe maternal morbidity, or SMM. This affects approximately 50,000 clients annually in the U.S. SMM refers to unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health and conditions requiring ICU admission, like cardiac arrest, respiratory failure, massive hemorrhage requiring large transfusions, eclampsia, sepsis, etc. This can occur in clients with known pre-existing conditions, but also, frighteningly, in previously healthy individuals.
And the disparities are significant here, too, aren't they?
Tragically, yes. There are significant and persistent racial and ethnic disparities. Black, American Indian, and Alaska Native clients experience maternal mortality in SMM at rates 2 to 3 times higher than white clients. Hispanic clients also face elevated risks. These disparities are rooted in complex factors including systemic inequities, implicit bias within healthcare, barriers to accessing quality care, and social determinants of health. Addressing these requires targeted public health strategies, quality improvement initiatives focused on equity, and culturally responsive care from all providers.
Most critical events don't just happen out of the blue, though. They're often preceded by subtle warning signs. How does that impact nurses and the need for collaboration?
You're absolutely right. Most critical deterioration is preceded by subtle warning signs, often changes in vital signs, like persistent tachycardia or tachypnea, sometimes changes in mental status, or maybe unexplained shortness of breath. Nurses, being at the bedside most consistently, are often the very first members of the team to recognize these red flags. This highlights the critical importance of prompt communication, using tools like SBIR, rapid bedside evaluation by providers when concerns are raised, and coordinated teamwork. Early recognition and response can literally be the difference between stabilization and irreversible deterioration.
What about when ICU transfer is needed?
When clients require intensive care, transferring a pregnant or newly postpartum client to a general ICU presents unique challenges. Ensuring that both maternal and fetal needs, if the fetus is still in utero and viable, are met simultaneously requires intense collaboration. This involves obstetricians, intensivists, ICU doctors, anesthesiologists, neonatologists, and specialized nurses from both OB and ICU. Often, an experienced OB nurse will accompany the client to the ICU and remain at the bedside, at least initially, to advocate for pregnancy-specific considerations and assist with fetal monitoring if needed.
And specifically, what are the implications for the fetus and newborn when the mother is critically ill?
Critical maternal illness almost always places the fetus at risk, unfortunately. Any condition that compromises maternal oxygen delivery, cardiac output, or systemic perfusion will directly impact placental blood flow and fetal well-being. For viable pregnancies where the mother is critically ill, continuous or frequent fetal surveillance is usually recommended. Decisions about interventions like administering corticosteroids, like betamethasone, for fetal lung maturity, or magnesium sulfate for fetal neuroprotection, if preterm delivery is anticipated or likely, are made collaboratively, always balancing the urgency of maternal stabilization with optimizing potential fetal outcomes. Sometimes, delivery becomes necessary to save the mother, even if the fetus is premature. #6. Critical care conditions in obstetrics.
Okay, we touched on hypovolemic shock earlier in the context of PPH, but let's dive deeper now into its critical care context, especially remembering how pregnancy can mask those early signs.
Right. In critical care, hypovolemic shock is understood fundamentally as a massive loss of circulating blood or fluid volume, leading to inadequate oxygen delivery to the body's tissues and vital organs. The body tries to compensate, as we discussed, increasing heart rate, shunting blood centrally, constricting vessels. But if volume isn't quickly and adequately restored, these compensatory mechanisms fail, leading to cellular hypoxia, anaerobic metabolism, lactic acidosis, multiple organ dysfunction, and potentially death.
What are the common triggers in pregnancy beyond PPH?
While severe PPH is the most common cause, other obstetric triggers include concealed hemorrhage from uterine rupture or placental abruption, massive bleeding during obstetric surgery, ruptured ectopic pregnancy, complications of placenta-accretus spectrum disorders, or even amniotic fluid embolism. Non-hemorrhagic causes can include significant fluid loss from conditions like sepsis, severe preeclampsia with HELP syndrome leading to capillary leak, hyperemesis gravidarum causing extreme dehydration, or diabetic ketoacidosis.
And the clinical presentation, again, emphasizing those masked signs.
Yes, it bears repeating. Pregnancy masks abnormal vital signs. The increased blood volume and physiological changes mean they can lose a significant amount of blood before classic signs like hypotension appear. So early signs are often subtle. Increased heart rate, persistent tachycardia, 110, 120, maybe rapid shallow breathing, tachypnea, 24. Falling blood pressure is a late and ominous sign. Look for other indicators: cool, pale, clammy skin as peripheral vessels constrict, decreased urine output, oliguria 30-metyl AHR, is a key sign of reduced kidney perfusion. Changes in mental status like restlessness, anxiety, or confusion indicate reduced brain perfusion. Pulses may become weak and thready.
So the goal of management.
The primary goals of clinical management are rapid: restore intravascular volume, achieve hemodynamic stability, increase oxygen carrying capacity, if hemorrhage is the cause, and improve tissue oxygen delivery. A critical nursing action, again, is recognizing those early warning signs: tachycardia, tachypnea, decreased urine output, restlessness, cool skin before the BP drops. Activate hemorrhage MTP protocols immediately for bleeding. Prepare for rapid infusion of warmed IV fluids and blood products. Support oxygenation with high-flow O2, and anticipate potential need for vasopressors or intubation if shock progresses.
This next complication is truly mind-bending, almost paradoxical, a situation where the body's own clotting system essentially turns against itself in chaos. Expert, let's untangle disseminated intravascular coagulation, or DIC.
DIC is one of the most feared complications in critical care, including obstetrics. It's a complex, life-threatening condition where the body's normal clotting cascade becomes massively and pathologically overactivated. This leads to widespread formation of tiny fibrin clots throughout the microcirculation small blood vessels. These microclots consume huge amounts of clotting factors and platelets faster than the body can produce them.
So you're clotting everywhere.
Yes, you get widespread microvascular thrombosis, which obstructs blood flow, leading to tissue hypoxia, ischemia, and potentially multiple organ damage. But at the same time, because all the clotting factors and platelets are used up.
You can't form clots where you need to.
Exactly. You develop a severe coagulopathy, leading to uncontrolled, often catastrophic bleeding from IV sites, surgical wounds, mucous membranes, or anywhere, really. So it's this dangerous paradox of simultaneous clotting and bleeding.
What triggers DIC in pregnancy?
Pregnancy itself is a hypercoagulable state, which slightly increases the baseline risk. In obstetrics, DIC is most often triggered by conditions that release large amounts of tissue factor, a potent clot activator, into the circulation or cause widespread endothelial damage. Common triggers include placental abruption, often the most common obstetric cause leading to hemorrhage and DIC, severe preeclampsia-HELP syndrome, amniotic fluid embolism, sepsis from chorioamnionitis or other sources, and sometimes retained intrauterine fetal demise, retained dead fetus.
How does it present clinically? It sounds like chaos.
It often presents with a rapid progression. Key signs include overt bleeding, oozing from IV sites, incision lines, gums, nosebleeds, epistaxis, development of petechiae, small red spots, or purpura, larger bruises, hematuria, blood and urine. There might also be signs of thrombosis like acrocyanosis, blue fingertips dose, or organ dysfunction, kidney failure, respiratory distress, altered mental status. And often signs of shock are present due to underlying cause or bleeding, hypotension, tachycardia.
Management must be complex.
Very. Management goals are threefold. 1. Treat the underlying cause aggressively, e.g. deliver the placenta in abruption, manage sepsis. 2. Support circulation and organ function. 3. Control bleeding and correct the coagulopathy. This involves aggressive volume resuscitation with IV fluids and blood products, often activating the MTP to provide balanced replacement of PRBCs, FFP for clotting factors, platelets, and cryoprecipitate, rich in fibrinogen. Specific factor concentrates might be used. Bleeding control might involve uterotonics, surgical intervention, or uterine tamponade. Continuous monitoring of vital signs, urine output, labs, coagulation panel, fibrinogen, D-dimer, platelet count, and organ function is essential, usually in an ICU setting.
Critical nursing action here.
Recognize those early signs of abnormal or uncontrolled bleeding in a high-risk patient like abruption or severe preeclampsia. Report them immediately. Prepare for rapid infusion of fluids and blood products. Anticipate and facilitate transfer to the ICU. It's about speed and coordination.
Now, for a rare but truly devastating event, often described with that profound sense of impending doom, tell us about amniotic fluid embolism, or AFE.
Amniotic fluid embolism, often now called anaphylactoid syndrome of pregnancy, is a rare but catastrophic obstetric emergency. It's thought to occur when amniotic fluid, fetal cells, hair, or other debris enters the maternal circulation, triggering a massive, abnormal maternal immune or inflammatory response.
So it's not just a physical blockage.
No, it's more like an anaphylactic reaction. This systemic response causes rapid onset of 1. Acute respiratory failure, sudden severe shortness of breath, hypoxia, respiratory arrest. 2. Cardiovascular collapse, sudden profound hypotension, shock, cardiac arrest. 3. Severe coagulopathy, essentially DIC, usually following the initial cardiopulmonary collapse. AFE carries a very high rate of maternal morbidity and mortality. Estimated mortality rates vary but can be upwards of 20–60% or even higher in some reports. Survivors often experience significant long-term neurologic injury due to hypoxia.
Are there known risk factors? Can we predict it?
Unfortunately, risk factors are not consistent or clearly predictive. It can happen in any pregnancy, often without warning. Some associations have been noted, like advanced maternal age, multiple gestation, placental abnormalities, previa, abruption, accreta, preeclampsia, operative vaginal delivery, or cesarean birth, but most cases occur in otherwise low-risk pregnancies.
How does it present? You mentioned sudden onset.
Yes, the hallmark is sudden onset, typically during labor, delivery, or within about 30 minutes postpartum. Early signs often include sudden shortness of breath or chest pain, sudden profound hypotension or shock, altered mental status, confusion, agitation, seizures, severe anxiety, and often that distinct sense of impending doom. If the client is still pregnant, sudden and severe fetal bradycardia or distress is often an early sign. It often progresses rapidly through 3 phases. First, respiratory failure and hypoxia. Second, left ventricular failure and cardiovascular collapse. And third, the coagulopathy E phase with massive hemorrhage.
Management sounds like an all-hands-on-deck emergency.
It is a true obstetric emergency, requiring immediate recognition and rapid coordinated response. There's no specific cure. Management is supportive. Goals are: manage respiratory failure, high-flow oxygen, intubation, mechanical ventilation, advanced life support, optimize hemodynamic function, aggressive IV fluids, potent vasopressors, CPR if needed, and correct the coagulation abnormalities, early activation of MTP. Other key interventions include calling for immediate help, rapid response team, code blue. If the patient is pregnant and viable, maintain left lateral uterine displacement to optimize cardiac output. If maternal cardiac arrest occurs and persists, perform a perimortem cesarean delivery, ideally within 4 to 5 minutes of arrest initiation, to potentially improve maternal resuscitation efforts and save the baby. Neonatal resuscitation teams should be present at the bedside. Providing support to the family during this terrifying event is also crucial.
Critical nursing actions.
Recognize those early warning signs immediately. Sudden SOB, profound hypotension, altered mental status, fetal bradycardia. Call for immediate help, don't delay. Activate emergency protocols. Assist with advanced resuscitation efforts, CPR, airway management. Administer medications, fluids, blood products as ordered rapidly. Ensure uterine displacement. Support the family. It's about acting fast and effectively as part of a team.
Let's pivot now to a metabolic emergency that takes on a new level of danger during pregnancy: diabetic ketoacidosis, or DKA.
DKA is a serious acute complication of diabetes, primarily type 1, but sometimes type 2, that is life-threatening for both the mother and the fetus when it occurs during pregnancy. Physiologically, it happens due to a relative or absolute lack of insulin. Without enough insulin, glucose can't enter cells for energy. The body starts breaking down fat and protein instead. This breakdown produces ketones, which are acidic, leading to hyperglycemia, high blood sugar, ketosis, ketone buildup, and metabolic acidosis. This also causes osmotic diuresis, leading to severe dehydration and electrolyte imbalances.
Why is pregnancy a vulnerable time for DKA?
Pregnancy itself makes clients with pre-existing diabetes more vulnerable. Placental hormones, like human placental lactogen, increase insulin resistance, especially in the 2nd and 3rd trimesters. There's also a state of accelerated starvation, where fasting periods lead to quicker ketone production. A critical insight here is that DKA in pregnancy can occur at lower blood glucose levels than in non-pregnant adults, sometimes with glucose only modestly elevated, maybe just over 180 or 200 mg/dL, whereas non-pregnant DKA usually involves much higher glucose levels. This can lead to delayed recognition if you're only looking for extreme hyperglycemia.
What usually triggers it in pregnancy?
Common triggers include intercurrent illness or infection, like UTI or respiratory infection, nausea and vomiting leading to dehydration and missed insulin doses, incorrect insulin dosage or pump malfunction, certain medications like corticosteroids given for fetal lung maturity or significant stress. Sometimes undiagnosed gestational diabetes can even present with DKA, although that's less common.
What does the client look like?
Clients with DKA usually appear very sick. They present with signs of hyperglycemia, polyuria, excessive urination, polydipsia, excessive thirst, significant nausea and vomiting, often severe abdominal pain, which can mimic other conditions like appendicitis or abruption. A classic sign is a fruity odor on the breath due to acetone, a type of ketone. They will also show signs of dehydration, dry mucous membranes, poor skin turgor, and potentially shock, tachycardia, hypotension. Neurological symptoms can range from weakness and confusion to altered mental status or even coma in severe cases. Rapid deep breathing, small respirations, is the body's attempt to blow off CO2 and compensate for the metabolic acidosis.
How is it managed?
DKA in pregnancy is a critical illness requiring prompt recognition and management, usually in an ICU setting. The primary goals are 1. Restore circulating volume with aggressive IV fluid resuscitation, often several liters in the first few hours. 2. Correct hyperglycemia gradually using a continuous IV infusion of regular insulin. 3. Correct electrolyte imbalances, particularly potassium, which often drops rapidly as insulin therapy starts, requires careful monitoring and replacement. 4. Identify and treat the underlying precipitating cause, for example, infection. A crucial nursing note. Continuous fetal monitoring is usually indicated once maternal stabilization is underway. Maternal acidosis and dehydration can quickly cause fetal distress or even demise. Correction of maternal DKA usually improves fetal status, but delivery decisions might be necessary depending on fetal condition and gestational age.
Okay, another critical condition. The lungs filling with fluid sounds terrifying, and you mentioned pregnancy makes it uniquely complex. Tell us about pulmonary edema in this context.
Pulmonary edema is the abnormal accumulation of excess fluid in the interstitial spaces and alveoli of the lungs. This fluid interferes with gas exchange, leading to hypoxemia, low oxygen in the blood, and potentially severe tissue hypoxia if not treated.
Why is it more complex or risky in pregnancy?
Pregnancy itself creates unique physiological changes that make the lungs more vulnerable to edema. There's a significant increase in total blood volume by about 40–50%, changes in plasma oncotic pressure, which helps hold fluid in vessels, and potentially altered pulmonary capillary permeability, especially in certain disease states. These factors lower the threshold at which edema can develop.
What causes it during pregnancy or postpartum?
Pulmonary edema in pregnancy can broadly be divided into 2 types based on the mechanism. 1. Cardiogenic pulmonary edema. This results from increased pressure within the pulmonary capillaries, forcing fluid out into the lung tissue. Common causes include excessive IV fluid administration, iatrogenic fluid overload, underlying maternal cardiac conditions like mitral stenosis, cardiomyopathy, or RHD we discussed earlier, being stressed by pregnancy's increased volume, or sometimes severe preeclampsia, causing high systemic pressures that back up into the lungs. 2. Non-cardiogenic pulmonary edema. This results from increased permeability of the pulmonary capillaries. The vessels become leaky, allowing fluid to escape even without high pressure. This is often associated with inflammatory states. Common obstetric causes include severe preeclampsia or eclampsia due to endothelial damage, sepsis, amniotic fluid embolism, or aspiration. Certain medications like tocolytics used to stop preterm labor can also contribute.
How does it present clinically? What are the signs?
It often has a sudden onset and can progress rapidly. Dyspnea, shortness of breath, especially with exertion or when lying flat, orthopnea, is often the first and most prominent sign. Clients may appear anxious, restless, and describe a feeling of air hunger. A persistent cough, sometimes producing frothy or pink-tinged sputum, and chest tightness are common. You'll observe tachypnea, rapid breathing, tachycardia, often 120 BPM, and decreased oxygen saturation, SpO Euro 95% on room air. They may use accessory muscles to breathe and prefer to sit upright. Diaphoresis, sweating, agitation, or cyanosis, bluish skin, indicate severe hypoxemia. Auscultation might reveal crackles or landlines in the lung bases, but importantly, crackles may not be present initially, especially in non-cardiogenic edema. Because symptoms can overlap with other respiratory issues, a high index of suspicion is needed.
What are the management goals and nursing implications?
The primary goal is to restore adequate oxygenation and stabilize the client. Management includes prompt oxygen therapy to maintain CO Euro 95%, often requiring high-flow O2 via mask, CPAP, or even intubation mechanical ventilation. Positioning is key. Typically sitting upright with legs dependent for cardiogenic edema to reduce venous return. Potentially lateral recumbent for non-cardiogenic edema if optimizing cardiac output is also a goal. Measures to reduce oxygen demand, like limiting activity, treating pain or fever, and decreasing anxiety. Diuretics, like furosemide, are often used for cardiogenic edema to remove excess fluid, but used cautiously or avoided in non-cardiogenic edema where the problem is leaky vessels, not necessarily volume overload. Careful monitoring of fluid balance is critical, usually requires an indwelling urinary catheter for accurate output measurement, precise IV fluid regulation using an infusion pump. Nurses must anticipate the potential for rapid deterioration and be prepared for interventions like intubation. Anticipation and early intervention are critical.
So the critical nursing action.
Pulmonary edema is a true obstetric emergency. Rapid recognition of dyspnea, hypoxemia, and tachycardia, coupled with immediate initiation of oxygen therapy, appropriate positioning, and prompt provider notification, can absolutely be life-saving.
This last one might sound like something from a history book, but you mentioned it as a cause of pulmonary edema. Why is rheumatic heart disease still relevant?
That's a great point. While rheumatic fever, the initial illness, is much less common in developed countries now thanks to antibiotics for strep throat, rheumatic heart disease, RHD, the long-term cardiac damage, still affects many individuals worldwide, including people immigrating to the U.S., and it poses significant risks during pregnancy.
Remind us how RHD develops.
Rheumatic fever is an autoimmune complication that can occur after an untreated group injury. A streptococcus infection, strep throat, or scarlet fever. The body's immune response mistakenly attacks its own tissues, particularly the heart valves, joints, skin, and brain. The acute phase can involve carditis, inflammation of the heart. Rheumatic heart disease, RHD, is the permanent damage that can result, most commonly affecting the heart valves. The mitral valve is most frequently involved, often leading to mitral stenosis, narrowing, or mitral regurgitation, leakiness, or both. Damaged valves don't open or close effectively. This forces the heart to work harder to pump blood, eventually leading to cardiac hypertrophy, enlargement, decreased cardiac output, arrhythmias, and potentially heart failure.
And why is this such a problem specifically in pregnancy?
Pregnancy places a tremendous extra workload on the heart. As we discussed, blood volume increases significantly, cardiac output rises, and heart rate increases. A healthy heart adapts to these changes. However, a heart with pre-existing damage from RHD, especially with stenotic narrowed valves like mitral stenosis, may not be able to cope with this increased demand. The narrowed valve restricts blood flow, causing pressure to back up into the lungs, leading to pulmonary congestion and a high risk of pulmonary edema, arrhythmias like atrial fibrillation or overt heart failure.
When is the risk highest?
While risk exists throughout pregnancy, the greatest danger for decompensation in clients with significant RHD, particularly mitral stenosis, is often during labor and delivery, and importantly, in the immediate postpartum period. After delivery, there's a large shift of fluid from the extravascular space back into the circulation, significantly increasing preload, the volume returning to the heart. A heart with a stenotic valve may be unable to handle this sudden volume surge, precipitating acute pulmonary edema.
So can you summarize that flow?
Sure. Untreated group A strep, potential for rheumatic fever, possible permanent heart valve damage, RHD, often mitral stenosis. Pregnancy increases cardiac workload, A volume, A output, AHR. Damaged narrowed valves cannot keep up TWOS. High risk for pulmonary edema, arrhythmias, heart failure, especially postpartum due to fluid shifts.
And the critical nursing action for these clients.
A client with any history of rheumatic fever or known rheumatic heart disease must be identified early in pregnancy and managed collaboratively by cardiology and obstetrics. They require very close monitoring throughout pregnancy, labor, and especially in the postpartum period for any signs of cardiac decompensation. This includes watching closely for dyspnea, orthopnea, needing to sit up to breathe, persistent tachycardia, cough, pulmonary crackles on auscultation, cyanosis, or peripheral edema. Early detection and management of decompensation are crucial.
Okay, wow. We've covered a tremendous amount of ground today, from the relatively common but still dangerous PPH to these complex critical care scenarios. Let's try to distill the absolute key takeaways for you, the nursing student listening.
Absolutely. It's a lot, but your vigilance is the common thread. Let's reiterate the main points. Postpartum hemorrhage, PPH, still the #1 cause of preventable maternal death globally. Remember the 4 T's to find the cause. Tone, most common. Trauma, tissue, thrombin. Your first-line actions are always fundal massage, assessing and emptying the bladder, and getting uterotonic medications going quickly. Quantify blood loss, don't guess.
Got it. PPH plus 4 T's, massage, bladder, meds, QBO.
Blood clots, DVT-PE. Pregnancy and postpartum are high-risk states due to Virchow's triad. Be highly suspicious. Watch carefully for leg pain, swelling, redness, warmth, DVT, and especially for sudden onset chest pain, shortness of breath, or tachycardia, PE. These are true medical emergencies requiring immediate action.
DVT-PE, high suspicion, leg signs, sudden chest breathing changes.
Infections, the uterus, C-section wounds, perineal lacerations, urinary tract, and breasts are all vulnerable sites after birth. Prevention through meticulous hygiene and thorough client education is crucial. Early recognition of fever, foul discharge, or localized signs, followed by prompt antibiotic therapy, is key to preventing serious complications like sepsis.
Infections prevention, hygiene. Teach warning signs, treat early.
Critical care emergencies, conditions like hypovolemic shock, DIC, amniotic fluid embolism, DKA, pulmonary edema, or decompensation from underlying conditions like RHD can develop suddenly and progress rapidly. As nurses, you must recognize the subtle early signs, act quickly, call for help immediately, initiate essential interventions like oxygen or fluids, activate emergency protocols, and support the client and family until advanced care arrives or stabilizes the situation.
Critical care. Recognize early signs. Act fast. Call help. Initiate basics.
The bottom line is you, the nurse at the bedside, are often the first person to notice that something is changing, that something is wrong. Trust your assessment skills. Trust your gut feeling when something seems off. Act quickly, communicate clearly, and escalate care appropriately. This knowledge isn't just for L&D nurses. You might encounter these critically ill postpartum clients in the ED, the ICU, or on a surgical floor. Being prepared can truly save lives. #outro.
So what does this all mean for you as you embark on or continue your nursing career? This deep dive wasn't just about memorizing facts and figures. It was really about preparing you for those intense moments when every second counts, when your training, your knowledge, and your instincts converge to make a potentially life-altering difference for a mother and her family.
That's right. The complexity of caring for a birthing person extends far beyond that single moment of birth. And given the sobering statistics around maternal morbidity and mortality, particularly the persistent and unacceptable disparities that exist, it really raises an important question for reflection. How will you use this in-depth understanding of postpartum complications and critical care obstetrics, not just to provide exceptional, vigilant, direct care at the bedside, but also perhaps to champion or contribute to systemic changes? Changes that are needed to ensure equitable access, respectful care, and ultimately life-saving outcomes for all families, regardless of their background or circumstances.
That's a powerful thought to end on.
We encourage you to reflect on the profound role you can play, not only as a skilled clinician, but also as an advocate for safer, more equitable maternal health care through continuous learning and speaking up when necessary.